Welcome to Chapter 15, entitled Pharmaceutical Care in Australia and New Zealand. Since the 1990s, pharmacists in Australia and New Zealand have had a strong tradition for providing pharmaceutical care in the form of innovative and advanced patient-focused clinical pharmacy services. The services have been developed over the years by academic pharmacists in collaboration with professional pharmacists organisations such as the Pharmaceutical Society of Australia, abbreviated as PSA, Pharmaceutical Society of New Zealand, abbreviated as PSNZ, and the Pharmacy Guild in both countries, abbreviated as PGA and PGNZ. These organizations also support pharmacists in the implementation of pharmaceutical care services, such as medication management review and chronic disease management and counseling activities. Next we will discuss community pharmacy structure in Australia and New Zealand. Pharmacists in Australia and New Zealand are key members of the healthcare workforce and can provide services across a number of settings which include community pharmacy, hospital pharmacy, both public and private systems, consultant pharmacy, aged care facilities, nursing homes, government and non-government organizations, industrial pharmacy and academia. The professional roles of pharmacists can vary across different practice settings but include the dispensing of prescription medicines, provision of medicines information, provision of primary care such as advice on management of minor and other illnesses, facilitation of consumer self-care, provision of professional cognitive pharmaceutical services, e.g., home medicines review, abbreviated as HMR, Residential Medication Management Review, abbreviated as RMMR, research and the development of health and medicines policy, amongst others. There are more than 27,000 practicing registered pharmacists in Australia and about 3,500 registered pharmacists and 1,200 technicians employed in various practice settings in New Zealand. The majority of registered pharmacists work in primary care in community pharmacy. The network of community pharmacies is extensive, with approximately 5,500 sites across Australia. With a current population of over 24 million, this means that each community pharmacy serves approximately 4,400 persons, on average. Each year, approximately 300 million prescription items are dispensed, with most prescriptions written by general medical practitioners. Similarly, in New Zealand, approximately 73% of pharmacists work in the community, and based on the National Pharmaceutical Collections extracts supplied by the Ministry of Health of New Zealand, approximately 43 million government-funded prescriptions were dispensed in 2016. The PSA and the PSNZ are the major professional organizations which represent pharmacists and oversee the scope of practice in both countries. These organizations are key providers of professional development and assessment, practice support and tools, and programs for pharmacists and pharmacies, amongst other roles. One significant contribution of the PSA is the authorship and publication of key documents to support pharmacists such as the Code of Ethics for Pharmacists and the National Competency Standards Framework for Pharmacists in Australia. In New Zealand, the Pharmacy Council of New Zealand, abbreviated as PCNZ, also publishes practice standards and guidelines for pharmacists, Code of Ethics 2011 and frameworks and competency standards for medicines management. The Pharmacy Guild of Australia, abbreviated as PGA, and the Pharmacy Guild of New Zealand, abbreviated as PGNZ, provide support and services to community pharmacy owners. The PGA has had a major role in negotiating 5-year agreements with the Commonwealth Government, known as community pharmacy agreements. Similar to Australia, The PGNZ provides leadership and negotiates contract with district health boards, abbreviated as DHBs, and the Pharmaceutical Management Agency, abbreviated as PHARMAC. PHARMAC is the Crown entity that decides funding of pharmaceuticals in New Zealand. In addition, to assist in maintaining professional competence and development, the Pharmacy Board of Australia requires all registered pharmacists to complete 40 continuing professional development points, 40 CPD points, on an annual basis. Importantly, half of the CPD points must be categorized as Group 2, Knowledge or Skill Improvement with Assessment, or Group 3, Facilitation of Quality or Practice Improvement activities, with the remainder as Group 1, Information without Assessment activities. In New Zealand, pharmacists applying for recertification must be enrolled in a recertification program, complete 20 points per year and 70 points per 3-year learning cycle. At least 10 points per 3 years must come from completing 2 significant learning goals, Group 3. Next we will discuss implemented services. Australian and New Zealand pharmacists have had a strong tradition for providing innovative and advanced patient-focused clinical pharmacy services for past 3 decades. Many of these services have stemmed from university practice-based research in collaboration with professional pharmacy organisations such as the Pharmacy Guild of Australia, Pharmaceutical Society of Australia, Society of Hospital Pharmacists of Australia, Pharmaceutical Society of New Zealand and the Pharmacy Council of New Zealand. Under the current 5-year Community Pharmacy Agreement, 6th CPA 2015-2020, a variety of professional pharmacy services have been implemented in Australia. These include, but are not limited to the following. 1. Dose administration aids, abbreviated as DAA. Dose administration aids are used to facilitate medication adherence. They are sealed, tamper-evident device that allows individual medicine doses to be organized according to the prescribed dose schedule. 2. Clinical interventions are designed to improve the quality use of medicines by identifying and resolving drug-related problems, usually at the point of dispensing medicines, in community pharmacy. 3. Staged supply of medicines occurs when the pharmacists dispense medicines in smaller quantities than usual, e.g., daily or weekly, to facilitate medication adherence and improved medication safety. The service is designed for consumers with a mental illness, or drug dependency or who have difficulty in managing their medicines safely. Medicine classes include benzodiazepines, antidepressants and analgesics. 4. Medication Management Review. These services include Home Medicines Review, abbreviated as HMR, Residential Medication Management Review, abbreviated as RMMR. HMR and RMMR will be described in more detail later in this chapter. 5. Meds Check and Diabetes Meds Check. These services are designed to facilitate the quality use of medicines and minimize adverse drug events. Meds Check and Diabetes Meds Check are in-pharmacy medication review services which focus on a brief consumer-focused review of the medication regimen, and the provision of education and self-management. 6. Rural support programs are designed to improve access to medicines and services for people living in rural and remote regions of Australia. 7. Aboriginal and Torres Strait Islander specific programs are culturally appropriate services designed to facilitate the quality use of medicines by Aboriginal and Torres Strait Islander consumers. Specific implemented services in New Zealand include the following. 1. Pharmacist prescribing. Pharmacist prescribers can work collaboratively in multidisciplinary teams providing services in either primary or secondary care. 2. Medicine use review and medication therapy assessment. In 2006, the Pharmaceutical Society of New Zealand, abbreviated as PSNZ, formulated a framework devised by a reference group for consumers, public health organizations, general practice, community pharmacy, and Maori and Pacific peoples to promote cognitive services. The cognitive services in the order of complexity included medicines use review and adherence support, medication therapy assessment and comprehensive medication review services. In alignment with NZPHCS strategy, these services are entrusted to public health organizations, abbreviated as FOS, to deliver and maintain the aforementioned services. 3. Immunization services. Pharmacists in New Zealand are uniquely placed to provide immunization services after completion of a vaccinator training program. Pharmacists must meet the same immunization and quality standards of the Ministry of Health similar to other vaccinators delivering this service. In a new initiative, supported by the Ministry of Health, from the 1st of April 2017, suitably trained pharmacists are able to provide funded influenza vaccination to pregnant women and older people, aged 65 and over. 4. Long-term care services. Registered pharmacists in New Zealand play a key role in recruiting patients into the long-term condition services and are helping optimizing medicines in this high-risk group. 5. Anticoagulation management services. Community pharmacists in New Zealand provide anticoagulation management services to a high-risk population requiring anticoagulation services. 6. Rheumatic fever prevention program. Registered pharmacists in New Zealand also participate in the rheumatic fever prevention program, whereby pharmacists take throat swabs and provide antibiotic treatment for high-risk populations for rheumatic fever. 7. Smoking cessation program. Community pharmacists in New Zealand have also played key roles in smoking cessation program. Next we will discuss interprofessional activities in Australia and New Zealand. At the organizational level, the PSA and PSNZ both support an interprofessional approach to the provision of pharmaceutical care. Indeed, for many professional cognitive pharmaceutical services, close collaboration with other members of the healthcare team is essential for their effective implementation. In Australia, medication management review services, i.e., HMR, RMMR, are key examples for which interprofessional communication is essential. Another approach supported by the PSA is the co-location pharmacists within general practice clinics. In New Zealand, the PSNZ and the New Zealand Medical Association, NZMA, have developed a framework model for pharmacists and general medical practitioners to work in multidisciplinary teams with a view to providing integrated, person-centered care for consumers. In addition, New Zealand is the first country in the Asia-Pacific to train specialist pharmacists, working in a multidisciplinary clinical health teams, to prescribe medicines. Registered pharmacists with extensive clinical experience undertake a postgraduate training certificate course in prescribing, and then register as prescribers with the Pharmacy Council of New Zealand. In 2013, the New Zealand legislation under the Medicines Regulations allowed pharmacists to prescribe. Pharmacist prescribers can work collaboratively in multidisciplinary teams providing services in either primary or secondary care. Pharmacist prescribers are part of multidisciplinary healthcare teams, and contribute to patient care as well reduce burden on general practitioners. Pharmacist prescribers in secondary care play a key role in reducing medication errors, particularly during transition of care from secondary to primary, where risk of medication errors at hospital discharge are likely to occur. At the curriculum level, the Australian Pharmacy Council, abbreviated as APC, is the authority that accredits pharmacy education and training in Australia and New Zealand. Specifically, the APC has the role of accrediting all registrable pharmacy degrees across all schools of pharmacy in both countries, N equals 20 universities. Importantly, one of the 6 learning domains evaluated, Learning Domain 5, Healthcare Systems and the Roles of Health Professionals, has a focus on interprofessional collaboration. It specifically states that interprofessional communication, teamwork and collaborative decision-making be included in all curricula. Hence, all accredited degree programs must contain elements in their curricula, which specifically address interprofessional activities. As an example, the University of Sydney offers a mandatory flagship interprofessional learning activity for all health discipline students, e.g., pharmacy, medicine, nursing, dentistry, physiotherapy, occupational therapy, speech pathology, diagnostic radiography, exercise physiology, nutrition and dietetics, which provides all students with an opportunity to work together in small interdisciplinary teams to solve an authentic complex case study. Next we will discuss pharmaceutical care in Australia and New Zealand. Although there have been numerous definitions and descriptions of pharmaceutical care published in the literature, the most well-recognized definition of pharmaceutical care was proposed by Hepler and Strand in 1990. They defined pharmaceutical care as the responsible provision of drug therapy for the purpose of achieving definite outcomes that improve a patient's quality of life. In 2013, following a process of expert consensus, PCNE redefined pharmaceutical care as the pharmacist's contribution to the care of individuals in order to optimize medicine's use and improve health outcomes. See also Chapter 1. Although the term pharmaceutical care is not universally used or recognized by healthcare professionals or consumers in either Australia or New Zealand, the professional role of pharmacists in optimizing medicine use with the goal of improving health outcomes is well established in both countries and embedded within university curricula. Hence, the PCNE definition of pharmaceutical care forms the basis for this section. And now we will look at counseling about medicines in Australia and New Zealand. Counseling patients about their use of medicines is a core role for community pharmacists, irrespective of whether the prescribed medicine is for acute or chronic purposes. For the latter, given that the standard quantity of medicines dispensed is for approximately 1 month's treatment, there is an ideal opportunity to counsel consumers about their use of medicines on a regular basis. More on counseling can also be found in Chapter 7. In both countries, written information sources, such as consumer information leaflets, in New Zealand, and consumer medicines information, abbreviated as CMI, documents, amongst other sources, are used to facilitate counseling. Consumer medicines information is a brand-specific written information source, authored by pharmaceutical companies, which can be used to assist counseling about the use of medicines. Consumer medicines information leaflets are available for prescription and some non-prescription medicines. They contain information on the safe and effective use of medicines. Specifically, consumer medicines informations contain the following information. 1. Name of the medicine. 2. Names of the active and inactive ingredients. 3. Dosage of the medicine. 4. What the medicine is used for and how it works. 5. Warnings and precautions, such as when the medicine should not be taken. 6. Interactions the medicine might have with food or other medicines. 7. How to use the medicine properly. 8. Side effects. 9. What to do in the case of an overdose. 10. How to store the medicine properly. 11. Name and address of the sponsor. And 12. Date the consumer medicines information was last updated. Next we will discuss medication management review in Australia and New Zealand. With the PCNE definition of pharmaceutical care in mind, there are two key government-funded services in Australia which have the explicit aim of optimizing medicine use. They are Residential Medication Management Review, abbreviated as RMMR, and Home Medicines Review. Both of these are research-underpinned, collaborative, comprehensive and patient-centered medication review services, provided by accredited pharmacists, for residents in aged care facilities, nursing homes, and those living at home, respectively. See Chapter 6 for more about medication review. We will now focus on Australia. The HMR and RMMR programs aim to achieve the quality use of medicines, abbreviated as QUM, that is the judicious, appropriate, safe, and efficacious use of medicines, as show WN in Table 15.1. HMR, which is also known as Domiciliary Medication Management Review, commenced in 2001. This Commonwealth-funded program aims to maximize patient benefit from medicines and prevent drug-related problems and their causes through a collaborative process involving both GPs and accredited pharmacists. Accredited pharmacists are those who have received post-registration certification in medication review from either the Australian Association of Consultant Pharmacy and/or the Society of Hospital Pharmacists of Australia. Together with RMMR, HMR forms a major pillar under Australia's medication management initiatives. There is much research evidence to support the HMR and RMMR programs, and so only selected findings are reported here. The impact of HMR and RMMR on Drug Burden Index, abbreviated as DBI, an objective pharmacologic outcome measure, have been evaluated. Nishtala and colleagues conducted a retrospective study of 500 RMMRs from 62 aged care facilities, and found a statistically significant reduction in median DBI scores, 0.5 to 0.33 post-RMMR. Similarly, Castellino and colleagues conducted a retrospective study of 372 HMRs from 155 pharmacists and also found a statistically significant reduction in median DBI scores, that is 0.5 to 0.22 post-HMR, in community-dwelling individuals. Hence, these studies demonstrated the effectiveness of both programs using a validated measure. Specifically, higher DBI scores indicate higher exposure to anticholinergic and sedative medicines which are associated with poorer physical and cognitive function. A detailed assessment of the specific recommendations made by pharmacists in 224 HMRs found that 910 or 964, that is 94.4%, recommendations were directly supported by evidence from recognized Australian national consensus and evidence-based guidelines covering all major therapeutic areas. This study was the first study reported in the literature to assess the quality of HMRs, using consensus and evidence-based guidelines as the measure. It is noted that only a small number of recommendations, n equals 54, 5.6%, did not accord with best available evidence. Pause the video and carefully scrutinize Table 15.1 summarizing the key steps in the Home Medicines Review and Residential Medication Management Review process before advancing to the next slide. Next we will focus on New Zealand. In New Zealand, the notion of pharmaceutical care emerged in 1990s. In 2007, the PCNZ endorsed patient-centered services via the National Pharmacy Services Framework. Medication management services outlined in this national framework aim to optimize medications involving pharmacists working collaboratively with multidisciplinary healthcare teams. The framework outlines 4 tiers of medication management services. Level A medicines provision, Level B medicines use review, abbreviated as MUR, Level C medicines therapy assessment, and Level D comprehensive medicines management, abbreviated as CMM. The medicines use review and medicines therapy assessment, abbreviated as MTA, services are currently offered in New Zealand, whilst the comprehensive medicines management proposed in the national framework has yet to be implemented. The overarching purpose of the medicines use review is to improve patients' adherence. In contrast, the medicines therapy assessment is a comprehensive medication review of the patient's medications undertaken by a pharmacist as a part of a multidisciplinary healthcare team. A retrospective evaluation of medication use review records of 353 patients in NZ found that this service improved patients' knowledge and perceptions of and adherence to medicines. To provide medicines therapy assessment services, pharmacists must be accredited and submit a portfolio of evidence against the medicines therapy assessment standards endorsed by the Pharmacy Council of New Zealand. The medicines therapy assessment services are not nationally funded in NZ. However, some district health boards in New Zealand do fund medicines therapy assessment services. A critical evaluation of the medicines therapy assessment service is not feasible given the paucity of either observational or interventional studies in this area. In New Zealand, pharmacists are granted prescribing rights. Pharmacist prescribing is a separate scope of practice and requires higher-level competencies than those required for levels B, C and D of the medicines management framework. The prerequisite qualification for entry into the pharmacist prescriber program is a postgraduate diploma in clinical pharmacy or equivalent. The current pharmacist prescribing model requires that pharmacist prescribers are required to work collaboratively in healthcare teams. The New Zealand model for pharmacist prescribing is that of independent prescribing, and pharmacists are independently responsible for prescribing. We will now look at medication management review reimbursement in Australia and New Zealand. Both HMR and RMMR aim to achieve the quality use of medicines, abbreviated as QUM, a tenet in line with Australia's national medicines policy. In recognition of the value of these services, both pharmacists and general medical practitioners receive a professional fee from the government for service provision, with no out-of-pocket expense for patients. Essentially, patients are selected for the services on the basis of need with some specific guidelines in place. These include discharge from hospital in the previous 4 weeks, significant change to the medication regimen in the past 3 months, change in medical condition or abilities, e.g., falls, cognition, physical function, use of a medicine with a narrow therapeutic index and that requires therapeutic monitoring, symptoms suggestive of an adverse drug reaction, subtherapeutic response to pharmacotherapy, noncompliance or problems with managing medication-related devices, risk of being or being unable to continue managing own medicines due to changes in dexterity, confusion, or impaired vision. In New Zealand, patients can receive the Medicines Use Review Service, Level B, by a referral from GPs, pharmacists, and nurses or nurse practitioners. The service can be conducted in the pharmacy, patient's home or by telephone. The funding for the services is via DHBs, and not all DHBs fund this service in New Zealand. On an average, pharmacists are paid up to $200 for 4 medicines use review consultations per year. GPs are not reimbursed for this service. Medicines therapy assessment, akin to the HMR service in Australia, is funded by a limited number of DHBs. However, the uptake of medicines therapy assessments since its introduction in 2007 has been limited. Thank you.